Okay, thank you all very much for coming and listening to this session. My name is Ben. You probably don't know a great deal about psychedelic medicine. Most people don't. Most people might consider that potentially controversial or unethical. I hope that by the time you get to the end of my session, you will realise, as we do in the field, that this is actually highly likely to be an important part of the future of psychiatry. It really does usher in a whole new paradigm for psychopharmacology and how we manage patients. So I'm a child and adolescent psychiatrist by training. In the last 8 years, I've been working in adult addictions. And for me, it's very clear that the cohort of adults in their 30s, 40s, 50s with addictions to harmful substances such as cocaine, methamphetamine, and alcohol and opiates are the same cohort of grown-up kids that I used to work with when I worked for many years in CAMS, in acute settings. And this slide is great. We all know about the risks, the public health concerns of obesity and diabetes, but it's sad just how many people don't understand this very clear developmental trajectory from early childhood trauma and pain into adult mental disorders, particularly addictions. So what have we got there? It's a scared, bruised, isolated, humiliated 10-year-old girl. Well, what is she going to look like at 40? Suddenly, she's scum. She's the public enemy. She's HIV positive. She's got one leg. She's sitting by the bus stop. She's addicted to alcohol. She wants you to give her a quid. Don't give her a quid. It's her fault. She did that. She could stop if she wanted to. It's a lifestyle choice. Now, that's outrageous. But that is sadly what happens. We seem to turn off our empathy switch. It's outrageous for two reasons. Firstly, we need to be deeply compassionate to all people, no matter how they behave or how they got there. But secondly, we're missing the science of this. And it's extremely frustrating as a professional to meet so many people, even within the healthcare profession, who just stigmatise and call these people a manipulator, a waste of space, a time waster. These are people, and there's very clear scientific reasons as to how they get to where they are. So when we talk about child abuse, we all know about the biggies, the ones that hit the social services radar, physical and sexual abuse. But I always say, don't take your eye off the ball when it comes to emotional abuse and neglect. I've worked with many patients over the years with severe psychological issues, particularly around addiction and personality disorder, where they haven't been physically or sexually abused. What they've experienced is, I don't love you, your dad doesn't love you either. We didn't want a boy, we wanted a girl. You're unlovable, you're worthless. Now, that drip psychological abuse is extremely, profoundly disturbing in terms of development of the human psyche. Child psychiatrists bang on about two things. One, boundaries. Two, attachment disorder. And attachment is the most fundamental part of the development of our personality. Attachment, the relationship you have with your primary caregiver, is the fundamental building blocks about the core parts of self. What is love? What is trust? What is friendship? Is it okay to lie? Is it okay to manipulate? You learn these things when you are that high, and it's very difficult to lose them. So we have a whole host of psychosocial factors that also impact on mental health problems, and all of these things like poverty and exclusion and poor housing and transgenerational unemployment and racism all contribute. And those of us that work in mental health services know that we work with people on the bottom rung of the ladder. We work with people with multiple risk factors that add together to produce the end phenotype. So all our work is holistic and multidisciplinary. It has to be. We need to attack it from all angles. So, bit of a physiology lesson here. That area in red is the amygdala. The amygdala is a very ancient part of the brain. We often talk about it in the mammalian brain. All mammals have this. It responds to fear and stress. And if you're a little child who, every time your caregiver comes into the room, you don't know if you're going to get kicked or punched or burned or raped, you develop an exaggerated amygdala response. You have physical brain changes in terms of network development during infancy, in which your amygdala becomes hyperreactive. You find things more frightening than others. Now, the green area there is the prefrontal cortex, and that's where we have a much more sophisticated human response. We use judgment and reasoning, logic. We can talk ourselves out of that instinctive bottom-up amygdala response with this much more sophisticated top-down prefrontal lobe response. Now, in the case of this damaged child who's been exposed to fear, you not only have an exaggerated amygdala response, you also have a shrunken prefrontal response. You're not very good at seeing the good in things. It's not actually an evolutionary adaptive good response to trust your caregiver. You're much safer off just believing that you're always going to be hurt. And the result is physical brain changes that then develop through life. Now, going back to the attachment, when you have the insecure attachment, you develop these narratives about self and the world. I am useless, I am a failure, I'm a bad person, it's my fault, I'm a slut, I deserve to be raped. And you develop narratives about the world. Everyone is dangerous, everyone is risky, don't trust people. It's interesting, I get people to look out of the window where I work in the addiction service in Weston-super-Mare, bearing in mind this is Weston-super-Mare, and I ask them to say, what do you think of the people down there on the street? And they say, he looks dodgy, she looks dodgy, she'd rip me off, he'd cheat. And I say, it's weird, because I look out the window and I say, he looks really nice, I bet she'd be my friend, I'm sure he'd help me if I needed some help. So there is no objective reality. We are all very much living in the narratives that we develop through the formation of these early psychological structures due to attachment. And it's very hard to treat them. And they're so difficult and overwhelming for people that a much, much easier approach is just to avoid, repress, and crucially, sedate, blunt the edges. Now, it's difficult to treat post-traumatic stress disorder, addictions, or any disorders that arise out of childhood trauma because of the rigidity of these narratives. There's no single drug treatment. We treat symptomatically. The patient's depressed, give them an antidepressant. If their mood goes up and down, give them a mood stabilizer. If they can't sleep, give them a hypnotic. If they're hypervigilance, one of the core features of PTSD, goes a little bit further and becomes paranoid, give them an antipsychotic. All of these drug treatments do not cure because they do not tackle trauma. They mask the overlying symptoms. And a good analogy would be if you had an infection due to a bug, a microorganism, one of the symptoms of that is a temperature, a fever. Now you can give ibuprofen or paracetamol to bring down your fever. Great, why not do that, feel a bit better. But it's not an antibiotic, it's not going to kill the bug. And when we give people SSRIs and antipsychotics and mood stabilizers for what are essentially trauma-based disorders, that's what we're doing. We're giving them a paracetamol to bring down their temperature. And it's one you have to take every single day, day in, day out, for weeks, months, decades, just to keep the symptoms at bay, without treating the cause. We also have many psychotherapies and trauma-focused work, CBT, DBT, EMDR, IPT, CAT, you name it. And psychologists in the audience may disagree and may be very wedded to one of these models, but 20 years in psychiatry has shown me that essentially the most important factor is engagement and connectivity and trust and emotional containment. And it's from here that you're able to talk about your pain. But what's so difficult with these dissociative-based disorders, trauma-based disorders, the patient by the time they're in their 30s, 40s, 50s is an absolute expert at not going there. They've become a heroin addict, they've become an alcoholic, they will do anything to not think about that night when they were 8 years old and their grandfather came into their bedroom. So when they sit down with a therapist and the therapist says, tell me about your rape, they're out the door and they're back to the vodka. Very difficult. So we have a 50% treatment resistance. It becomes a chronic disorder, PTSD, in half the people. Now, I want to talk about this legal high, alcohol. I have an immense problem with this in this country, much more so than we perhaps give ourselves credit for. It is almost usually linked to undiagnosed PTSD. Trauma occurs in the majority of cases of these severe chronic addictions. It's a massive clinical burden, financial burden in the UK, and we're sitting on a time bomb. So how well are we doing to treat alcohol use disorder in this country? Well, the very best that the medical profession can throw at you, anti-craving drugs, rehab, inpatient care, group therapy, one-to-one therapy, MAP groups, AA, the very best that we can throw at people today with alcohol use disorder. And we've got around 80 to 90% of people drinking again within 3 or 4 years. This is outrageous. this is a terrible outcome. I can't think of any other parts of medicine that would accept this kind of an outcome after 100 years of modern psychiatry. We were doing better at treating alcoholism in the Victorian times than we are today. It's outrageous. So we thought we'd do a little treatment as usual, observational study before our main MDMA study. We just took people, screened them before detox, they had an alcohol detox. We then let them go into treatment as usual. We didn't interfere with any of that, and then we looked at them at 3, 6, and 9 months, and our outcomes there are pretty standard. About 80% of people are drinking again, a few aren't. So that's what we were dealing with in Bristol. We should be doing better than this, okay? We've taken our eye off the ball on treating addictions in this country, but throughout the world, and there are many complex reasons for that. Now, 3,4-methylene-dioxymethamphetamine is quite an interesting molecule. I would suggest that this is psychiatry's antibiotic. But will it treat alcohol dependency? Now, there's been a lot of work done in addictions with the classic psychedelics, LSD and psilocybin, ketamine to some extent. In fact, most of the work done in the 50s with LSD psychotherapy was directed towards alcoholics. So it's got a very rich history, and what all of those old studies and the contemporary studies, because we've been revisiting these studies with psilocybin therapy in the last few years, what all of them find is the most therapeutic part of the psychedelic experience is this peak experience, a mystical experience, this sense of being with another, this sense of having your mind blown. And this kind of translates into a sobriety in a significant number of people when they glimpse this other side. Now, MDMA doesn't typically produce a psychospiritual experience or mystical experience. About 5 or 10% of first-time threshold dose MDMA users will report a mystical experience, union with God, that kind of thing. But most don't. And that compares with the 80 to 90% that report a mystical experience with the classic psychedelics, LSD and psilocybin. So for that reason, it might not work, we thought, when we started the study. But what we do know is that it works really well with trauma and empathy. And we know that alcoholics have high levels of trauma, so we put 2 and 2 together and thought we'd do this. And what we did is we started, and we are still doing, the world's first MDMA-assisted psychotherapy study to treat an addiction. So, the perfect tool for trauma psychotherapy. If you're going to invent a molecule, you come up with MDMA. Short-acting, mildly perceptually distorting, but nothing like the classic psychedelics. We're not talking sort of dripping walls and melting faces, but enough to just make you think outside the box. Almost always pleasurable. That's a very important feature in therapy. It's tolerated. You don't really have a bad trip on MDMA. It either works or it doesn't, but it's a very pleasant experience. There are a few drugs in psychopharmacology that have such a invariably pleasurable effect. Another is the opiates. I always say to my medical students, if you don't like heroin, you don't have a brain. You need to go and see a neurologist about that. There are some drugs that are hardwired to be relatively pleasurable, and MDMA is one of them. Very safe as well. I've been talking about MDMA for 15 years in these kinds of forums. I used to put up loads and loads of data and graphs about ecstasy users. I just don't bother. If you want more data, you can find it. It is a staggeringly safe drug. We kind of know that from the fact that we've been doing a 25-year anecdotal epidemiological study in the UK with 750,000 doses of ecstasy taken every weekend for 25 years, yet the rates of morbidity and mortality are staggeringly low. So it's a very safe drug. We know about this within public health concerns or drug services by now if it was a particularly dangerous drug. MDMA, you can classify the psychedelics roughly into these groups of tryptamines and phenethylamines, and MDMA is a phenethylamine. Tryptamine and phenethylamine are both precursors in neurotransmitter synthesis, which does lead some scholars to suggest that we may all possess endogenous psychedelics that are at play when we have non-drug spiritual experiences, and that's another big story. It's also what in this group we call the entactogens, along with MDA and others in the 2C series. So that's where it sort of sits in terms of psychedelics. Now, this is an interesting slide. So how does MDMA work? Well, what most people think is, it increases serotonin. Well, it's a bit more sophisticated than that. We have increased activity at the 5-HT1A and 1B receptors, and that's the positively felt mood, the reduction in anxiety and depression. We also have this 5-HT2A activity, which is where the classics work, but as I said, much less pronounced than LSD and psilocybin. Then we have this interesting paradoxical relationship going on between the stimulation as a result of the amphetamine part of the molecule, which is dopamine, noradrenaline activity, counterbalanced by this alpha-1 and 2 receptor activity, which causes a relaxation. And those of you who have tried MDMA, which I would imagine is a considerable number of you, might be familiar with this. It's very popular, second to cannabis as a recreational drug. It's this peculiar paradoxical being speeded up and slowed down at the same time. From a psychotherapeutic point of view, what this does is it puts you into this perfect optimal arousal zone. You're speeded up enough to engage in therapy, but the relaxation part takes the edge off that hypervigilance when it comes to trauma recall. And then we have, of course, this hormonal effect at the hypothalamus with oxytocin, which is the hormone released from the brains of breastfeeding mothers, a hormone that engenders a sense of attachment and bonding. And here's our child's brain with this exaggerated amygdala response and shrunken prefrontal response, this excessive reaction to fear, and this inability to use logical reasoning to overcome that knee-jerk reaction. And this is from a study that we did at Imperial in 2012. MDMA completely reverses this. You do not find things as frightening as you normally would, and you're able to see the good in things much better. Now, this is really important in trauma-focused psychotherapy, where it's that high level of fear and dissociation that prevents you progressing through psychotherapy. I would sum up the effects of MDMA with this statement: it selectively inhibits the fear response whilst leaving the other faculties intact. That's a very important statement. Many drugs inhibit fear response. A bag of heroin will inhibit your fear response. A bottle of vodka will inhibit your fear response, which is why these are the two primary choices for people with trauma. But they're very messy drugs. You can't work on those drugs. You can't remember what you're talking about. With MDMA, I always ask the patients the next day, you talked for 6 hours yesterday about all sorts of interesting things. Do you even remember it? Were you just talking gobbledygook? Were you just high? And they say, yes, I was high, but I remember all of it. In fact, I was thinking more clearly than usual. And they find themselves, having never been able to talk about these things, having repressed these and avoided these memories for 20, 30, 40 years, they can sit there for 8 hours and talk in great detail about their trauma. And that begins the healing process. And this selective fear response, I'll share with you an anecdote. When I was 18 years old, taking ecstasy with my friends, this is before I went to medical school, in 1990, I was a DJ in the 90s as well, so I was kind of exposed to a lot of this. And we were all lying there after this rave, and someone went, oh man, this is so beautiful. Let's try and think of the worst thing in the world. And we all lay there and went, oh man, imagine our mums dying. And then we all went, it's not that bad. And that's really interesting, because this is long before I heard about this sort of work, but that's kind of what we do with MDMA. It allows you to go to places you wouldn't normally go to. So if we translate that in, can we talk about your rape when you were a child? Yes, I can. I've never been able to, but I can. So we are doing an open-label safety and tolerability study. There is no control group. There is no placebo. Now that might sound very methodologically unsound, but that's what you have to do when it's a first-time drug in a new group. 2 sessions of MDMA. We take them out of detox. They have an 8-week course of psychotherapy, and they take MDMA on session 3 and session 7, interspersed with non-drug sessions. They take 125 milligrams, followed by 62.5 at each session. And then we follow them up for 3, 6, and 9 months. So this is like the observational study we did, but with the 8-week MDMA therapy course slotted in. Yeah, so MDMA is not recreational ecstasy, and that's really important. It's like comparing an appendectomy with someone who chooses to take out their appendix with a pair of rusty scissors on the kitchen table. You wouldn't say to a surgeon, you can't do appendectomies, because what about those people who take their appendixes out on the kitchen table? We can't compare the two. Recreational ecstasy is something very different indeed, and the rates of morbidity are low. 5 deaths a year, perhaps, attributed solely to MDMA, all of which could be easily avoided with just some decent drug education. You can bet your life that those 5 deaths appear on the front page of the Sun. So MDMA is a remarkably safe drug. This is David Nutt's Delphic analysis of 20 different drugs, and Here we have the psychedelics languishing down there at the bottom, way behind the others. This is the Misuse of Drugs Act. If you learn nothing today, go to your MP and tell them to urgently review the Misuse of Drugs Act. It is unethical, it is unpoliceable, it is wholly unscientific. There's more evidence for crystal healing, which solving the drug problem, than there is for the Misuse of Drugs Act. So, a few shots of our clinic set up. Some qualitative statements there. So it's a safety and tolerability study at this stage. We can't really make a meaningful interpretation about efficacy data without a placebo control group. But we've got some really positive data around safety and efficacy, which was the main intention. MDMA has changed my life. People talk about how they've never been able to go there, and now they can go there and start resolving these things. And the crucial thing is it lasts. You don't have to keep taking it. You only take MDMA twice, and then they come off all their SSRIs. This is the antithesis of psychiatric prescribing. This is a cure. We don't use that cure word in psychiatry. We've become so used to being palliative care doctors, being alongside our patients for life. And because that's the truth. If you were severely abused as a child and you're presenting with anxiety-based or addiction problems in your 20s, you'll probably be going back to your psychiatrist in your 60s. That's not good enough. Why can't we cure people? Why can't we get them out the door like all the rest of the medical profession does? We were published in BMJ last month. Very physiologically tolerated, mild rise in temperature and blood pressure. No post-MDMA affect drop. This Black Monday, Blue Tuesday, Suicide Wednesday that ravers talk about, we don't see that. That's an anecdote of raving. That's not about MDMA. Here are our outcomes so far, kind of the opposite. Almost everyone's not drinking. We've got 2 who've returned to previous levels of drinking. And a few who've had 1 or 2 drinks but not returned to previous levels of drinking. That's a really interesting outcome. We've got to look at that more closely. If it turns out that Mdma-Assisted psychotherapy for alcoholism allows you to return to become a moderate drinker, that would be a big, big step forward in addictions. So just to sum up, psychedelic research is a really interesting place to work. A lot of work being done all over the world by a wonderful group of people. Unfortunately, way too many white middle-class men, which is something we need to tackle. I've been involved in all of these groups with psilocybin and DMT and MDMA and LSD and ketamine over the last 10 years. I've been injected intravenously with all of these as a healthy test subject on all those trials we've done, and I'm okay. So just to finish, this is Michael Mithoff, the pioneer of Mdma-Assisted psychotherapy in the States. A lot of people say to me, a lot of young people come to me and they say, I'm really interested in psychedelic medicine, but I spoke to my tutor about it and they said, you're crazy, this is career suicide. And when I was in Oxford as a trainee 15 years ago, that's what they said to me. Why are you doing this, Ben? Why are you aligning yourself with these crazy hippies? Why don't you study something nice and wholesome like SSRIs? Now, if there are people in the audience who might be interested in this, and that's what you're hearing, you need to just say to your tutors, open your journals. Not a month goes by that we don't have peer-reviewed, published work on psychedelic studies. This is not some fringe subject. This is not some crazy thing just done by a bunch of weirdos in California. This is cutting-edge neuroscience. All these major neuroscientific institutions are running psychedelic research programs now. Those of us in the field truly believe that this is ushering in a whole new paradigm for psychiatry. For too long, we've just been treating people with maintenance medications that mask the symptoms. We can cure people. We can get them out the door. We owe it to those patients. We owe it to this little girl. Thank you.